evening, my dear friends and respected surgeons from various parts of India. So, my talk is made very simple by Dr. Anupama's beautiful talk on classification and classification of pilonidal sinus. So, I am going to discuss here on role of flaps in pilonidal sinus. So, introduction is already done. So, I would like to, these are the theories, Bascom theory, Karidakis theory and Stelner's theory, which have been used for pilonidal sinus. This is the area most commonly present. So, now what are the common surgical approaches for treating chronic pilonidal sinus? So, we are not discussing about acute, only chronic. So, the important thing is excision and wound closure. So, excision and wound closure is mainly for just primary closure, which is not really the proper choice. The main thing are what are called as flaps. The flaps are divided as Z-plasty, VY advancement flap and rhomboid flap. Also in plastic surgery they use larger gluteal flaps which are requiring advanced surgical techniques. So Karidakis surgery mainly believes in getting the closure from the midline to the lateral. So what it is the excision is done and the closure is made as a flap which is placed on the lateral side. So from the midline closure, the pit is removed, and once the pit is removed, the closure is done on the base and the flap is closed on a lateral side. The concept is a very simple concept. What becomes the natal cleft is made more shallow. So once it is made more shallow, the chances of recurrence is less. So these are certain pictures of the Karidakis technique. So it can be done even under local anesthesia. However, it is preferred with a proper anesthesia. The next technique is what we call as the Z-plasty. So you can see this is not showing. So in the Z-plasty, the main central part is removed and the flaps are taken from the opposing end and covered as a Z. So this prevents a direct pressure over the natal cleft area, leading to healing. The other one is the VY plasty. This is a standard technique wherein an excision is done and mobilization of lateral flap is done. The last has been, which is more widely used, is called the LIMBERG flap. LIMBERG flap involves an excision of a rhomboid shaped pilonidal sinus, excision along till the presacral fascia, and once it is done, a lateral flap is mobilized. The lateral flap is mobilized and placed into the area. So as you can see, once the central flap, excision is done, the flap is raised and placed over the raw area. Once this is done, the chance of recurrence is quite low. However, it involves the patient to cooperate very well for all these flaps, that the patient has to be immobilized and being on the, preferably not going around and not lying on that side. So it should be not having pressure. So this makes the patient off the work for some period of time. At least our recommendation always is 2 weeks that this patient takes off such that this flap doesn't get damaged. If we do not allow them, if we allow them to be mobilized and go to their work, then they will damage the flap and come back. So these are some of the trials. Time to wound healing has been quite good in the open versus flap technique. So the flap techniques have healed in about 2 or 3 months. So the primary closure has its own advantage, but over a period of time, the recurrence is higher. So the recurrence rate in primary wound closure is higher compared to that of the flap. So also the surgical site infection, there has been no major difference, but the problem is that with 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 with